I'm sure you've all had your primary care. Let me go through this quite quickly because you do the primary care, but primary care initiative was set up in Alberta, and we feel we had a special one in the south to deliver this. And of course we wanted to have quality, and we set up learning sessions to get away from the old paradigm of a doctor just seeing one person, one visit, one issue, and then it's not their responsibility, to get a system where a physician is responsible for a panel or population of people, and as soon as they become responsible for that panel, they soon see they can't do it by themselves. A team is absolutely vital, and with that team they're able to take care of the appropriate things they need to take care of for prevention, chronic disease management, and those processes. People would like to have their provider. I'll just go quickly here. But the measurement system is the panel. Now, could I just ask you, just so I don't waste your time, who knows what a panel is? Okay, so I'll just take a second. A panel is a discrete number of people for which I, the physician, am responsible for. So if you take it, if I'm responsible for these 1,500 people, I should be responsible for all their preventative and chronic disease needs. It's a way that you can measure what I do, and if you coalesce all the panels, we should then be able to take care of all the population, because then everyone should have someone that's responsible for them rather than no one responsible for them. It just happens if they come in. In Alberta, we have the dismal statistic that probably about, if you take something like diabetes, 29% of the tasks that should be done for diabetics, for maintenance of chronic disease, are being done. If you take hypertension, 50% of males over 50 have uncontrolled hypertension. So we're just building a $1.2 billion hospital in Calgary because we're already at 800 acute care patient days per 1,000, and some of the better systems like Kaiser run at 330 acute care patient days per 1,000. Because why? We haven't taken care of the preventative stuff, so now we can do cabbages for all the people that really shouldn't be having them in the first place. So the measure that we like to measure the physicians against to see if they're doing what they should be doing is this panel. The panel is this population. And it's also adjusted by age and sex, and in some places by diagnosis. And once you start doing this, you can see some very interesting things. And this is just a quick idea of just one group that I saw. You can see that Dr. A has a nice panel of about 1,934 people adjusted, and he sees them 4,200 times. So he has a return visit rate of 2.7, and there's only about a couple of hundred of those people that are seen by other people. So he's taking care of them. He has a continuity, very high continuity. And in the world of advanced access, continuity is king, because if people see other people, then it's just waste, and I'll talk about that in a second. On the same token, we can see another doctor, Dr. F, has a panel of about 3,000, but he's seen them 18,000 times with a return visit rate of 6+. And but they're seeing about 4,000 of those people are seeing other people. So he has as many people spilling over as the first doctor is actually seeing. So you begin to wonder what's the value. And so I've had discussions with Alberta Health and Wellness about, why would we keep rewarding fee-for-service when it provokes this type of behavior? If a person's seen by their own doctor, there's X amount of chance that they'll be seen again. If they're seen by a doctor in the same clinic, not their own, there's twice as much chance in the next 2 weeks that they'll be seen for the same illness. If they're seen by just a doctor in an emergency walk-in, it's 4 times the risk. So think of how much it's costing the taxpayer and see how we develop the system. So delays cost money. Delays have you see other people, and so we spent a lot of time getting rid of delays, because the average doctor 2 years ago would have had a delay of 6 to 8 weeks, I would say. But you know, that's good for a doctor. I know I got 6 or 8 people parked in my parking lot. That means people love me. They care about me. And I know I've got business to come to. But it's not really taking care of the folks. And so it's dissatisfaction all around. And I think you have the same type of wait list as others. If we could get rid of that delay of seeing the physician, just like snapshot statistics show, there'd be a 14% decrease in what comes to the emergency. So we went through the exercise with the docs of checking their demand and their variation, their backlog. Backlog's a really interesting one. Ask them, what was your wait list last year? Oh, about 3 months. What was it the year before? Oh, about 3 months. What's it now? About 3 months. Well, actually then, they have the same demand and their supply, they're matching, they're just late. If you could get rid of that delay, they'd be taking care of it all the time. And what they also find out, that if you're working with that backlog all the time, you have to set systems in place to say, golly, who's the sick ones? I better get a triage system. So now I got to take 20 to 25% of my resources out of the pack to be able to take care of triaging. Well, guess what? If you didn't have to triage, you'd have 20% more ability to work. We had our regional programs work with the physicians' clinics as we did this. One of the programs, bless their hearts, didn't see it for a long time. They actually went through 4 sessions before all of a sudden it turned their lights on. That was mental health. They were spending over 40% of their time checking to see who were the people that needed to be seen because they were so busy because they were 3 months behind. So finally they got the idea that maybe if they didn't spend the time thinking, and we went through the process of scheduling and making, you know, working it all, well, within 8 months, they came down, like I told you earlier, and had 3-day delay. Can you imagine the difference to our system now by having the mental health workers been able to see people between 1 and 3 days and not have to have a triage system? The whole, it's you know, think of the value, and again, your title of your doing this is trying to have better quality, being more efficient. Like I'm on this McKinsey planning group for the new Alberta to see what strategic planning we should do, and mental health is right up there. You know, we have to do something with mental health. So what program should we set up? What program should we set up? Well, maybe we shouldn't set up a program. Maybe what we should do is just do what we do right and not have the delay. If we had this primary care group and the mental health clinics taking care of people same day, that would certainly be the first step in my mind in the next couple of years to get where we need to go.